All right, this is our presentation for Decubitus ulcers by
Melissa Harkins.
Jackie Sauer.
Madonna Stroud.
and Anthony Lobos, and this is for Nursing 238, Gerontology and Community Health Nursing.
Okay, so we're going to be discussing decubitus ulcers, and our introduction is what are pressure ulcers. Bed sores, also called pressure ulcers, and decubitus ulcers are injuries to skin and underlying tissue resulting from prolonged pressure on the skin. Pressure sores are areas of damaged skin caused by staying in one position for too long. They commonly form where bones are close to your skin, such as your ankles, elbows, heels, and hips. Anyone is at risk to develop a bed sore if they are bedridden, use a wheelchair, or are unable to change their position.
Decubitus ulcers result when there is a loss of tissue integrity due to skin and underlying soft tissues, when they are pressed between a bony prominence and an external surface for an extended period of time. They occur most often from limited mobility. A patient who has limited mobility has a greater chance of developing an ulcer because they can't change their position in order to relieve the pressure. In a patient who can't feel the pain or communicate, it is more likely for them to develop pressure ulcers as well.
Three primary contributing factors for bed sores include pressure, which is a constant pressure on any part of the body, which can lead to lessened blood flow to the tissue. Friction. Friction occurs when the skin rubs against clothing or bedding. It can make fragile skin more vulnerable to injury, especially if the skin is always moist. Shear. Shearing occurs when two surfaces move in the opposite direction.
Additional causes that increase the risk of skin breakdown are poor nutrition, especially a lack of protein. Lack of protein also delays healing of a skin breakdown. The prevalence of pre-existing pressure ulcers at the time of admission to an acute hospital was 26.2% among those admitted from a nursing home and 4.8% among those admitted from another living situation. The odds ratio 5.5, 95% confidence interval, 4.3 to 7.1. After adjustment for confounders, the association between admission from a nursing home and pressure ulcer prevalence on admission was reduced. These results indicated that admission from a nursing home is a potent marker for pressure ulcer risk and that the excess is largely mediated by a higher prevalence of pressure ulcer risk factors among patients admitted from a nursing home. The results highlight the importance of continuity of care across transitions between care settings.
So before I start this video, this is going to be a visual representation of the different stages of ulcers. We have 4 stages of ulcers, which will be demonstrated right here by Madonna Stroud. And just to give you guys a little bit of a better idea so that you guys will know what to look for. So I'll go ahead and play this.
Okay, today we will be discussing pressure ulcers, also known as decubitus ulcers, sometimes referred to as bed sores. This would be considered a stage 1. It's non-blanchable redness. Moving on to a stage 2, pressure ulcer. Here we have a stage 3, pressure ulcer, with subcutaneous fat, slough, undermining, and tunneling. We have undermining under here. There's tunneling down in there. Once again, this is a stage 3 pressure ulcer with subcutaneous fat, slough, granulation tissue, undermining, and tunneling present. I'm going to move on over to an unstageable pressure ulcer. It has eschar, slough, and it has more than 50% non-viable tissue, so that makes it unstageable. We're not able to stage this particular ulcer. Okay. Finally, here we have a stage 4 pressure ulcer. This ulcer has eschar, subcutaneous fat, undermining, tunneling, slough. There's exposed bone. This can possibly lead to osteomyelitis. We also have rolled wound edges. And so here we have the undermining down in there. And we have tunneling here. This is a very involved pressure ulcer. Once again, we have a stage 1 pressure ulcer, unblanchable redness. Stage 2 pressure ulcer. Stage 3 pressure ulcer, which also has subcutaneous fat, slough, undermining and tunneling. Undermining and tunneling. Unstageable pressure ulcer. And finally, the stage 4 pressure ulcer, which has the exposed bone, which can definitely lead to osteomyelitis.
All right, and those are the various stages of ulcers. Whoops. Next slide. Prevention.
Pressure ulcers can be prevented if the risk is recognized and intervention begins early. A pressure ulcer prevention program consists of 2 steps. 1 is early identification of high-risk patients, and 2 is implementation of aggressive intervention for prevention with the use of pressure relief or pressure reduction devices. Now, positioning for prevention is pad contact surfaces with foam, silicone gel, air pads, or other pressure relieving pads. Don't keep the head of the bed elevated above 30 degrees. Use a lift sheet to move patients in the bed to avoid dragging or sliding him or her. When positioning a patient on his or her side, do not position directly on the trochanter. Reposition an immobile patient at least every 2 hours while in bed, and at least every 1 hour while sitting in the chair. Do not place a rubber ring or a donut underneath the patient's sacral area. When moving an immobile patient from bed to another surface, use a designated slide board well lubricated with talc or the use of a mechanical lift. Place pillows or foam wedges between 2 bony surfaces, and keep the patient's skin directly off plastic surfaces. Keep the patient's heels off the bed surface using bed pillows under ankles. Now, skincare. Perform a daily inspection of patient's entire skin. Document and report any manifestations of skin infection. Use moisturizers daily on dry skin and apply when the skin is damp. Keep moisture from prolonged contact with skin. Dry areas where 2 skin surfaces touch, such as the axilla or under the breasts. Place absorbent pads under areas where perspiration collects. Use moisture barriers on skin where wound drainage or incontinence occurs. Do not massage bony prominences, and humidify the room. Skin cleaning. You want to make sure that you clean the skin as soon as possible after soiling occurs. Use a mild, heavy, fatted soap or gentle commercial cleanser. Use tepid rather than hot water. In the perineal area, use disposable cleaning cloths that contain a skin barrier agent. While cleaning, use the minimal scrubbing force necessary. Gently pat rather than rub the skin, and do not use powders or talc directly on the perineum. After cleansing, apply a commercial skin barrier to those areas in frequent contact with urine or feces. And then here's the Braden skin scale that just is a scale that is used to rate the areas of skin breakdown.
And that's just the table right there that nurses generally use to grade it. Now, nutrition, probably one of the most overlooked and underestimated aspects of this. It is a really large factor in ulcer prevention. And a lot of people don't know that proper nutrients can help you keep you strong. So it's it's encouraged that they at least intake between 2 to 3,000 mLs of fluid per day. So 2 to 3 liters of water or any form of low sugar fluid. A diet should be high in proteins and high in calories. So it doesn't have to be a big meal. So probably something like nuts, uh, protein supplements, meal replacements. Even if the patient's overweight, you can still be malnourished. So it's essential that we ensure that they get the proper nutrition. So I guess the the ballpark, the amount of protein they should get is 1.25 to 1.5 grams of protein per kilogram, and then we want to make sure that we get vitamin A, C, E, folic acid, iron, and zinc. So a lot of these we can find in fruits and veggies. So we want to find out what the patient's eating habits are. We want to make it a comfortable environment for them so that we know that they'll be